Hi, I'm Doug Dormer. This is the Business of Health Informatics B641. This is Module 4, Lesson 2, when we'll take a closer look at the telehealth and disproportionate share hospitals that are under debate and under dispute between the One Big Beautiful Budget Bill and the current debate over the appropriation bill during the government shutdown. Here we look at the expiration of telehealth waivers, originating site geography, meaning you can't have it at your home anymore, provider eligibility, therapists, certain allied health professionals may no longer be able to bill, audio only, telephone calls are no longer allowed, only video, FQHCs no longer allowed to act as a distant site. In other words, you can't have your call to the FQHC and call that as your telehealth encounter. You may go there and they may connect if you meet other geography requirements. They may call someone else with you in their office. That may qualify not for billing as the FQHC for telehealth, but for the remote party from the FQHC. The hospital at home is something we could spend a lot of time all by ourselves, but we'll let this be fairly succinct for this conversation because I think it's clear. The waiver has expired now, obliging hospitals to discharge or transfer patients currently in receiving acute level home care. Now, all of these have expired as of October 1st and can no longer be billed to Medicare. Will they be a part of a reconciliation package? Whether they'll be part of a continuing resolution or an appropriation bill, we don't know. I believe they will be, and I believe that all of these are temporary, but we won't know because right now they are not the law. You can see the impact. The short version is it affects those most vulnerable, people who since 2020 have said, this is a pretty good way to work. It affects providers that have been delivering these services as well. So what are the consequences for health IT from these expiring telehealth waivers? How do we turn off our telehealth scheduling system for Medicare patients only? How do we inform our staff and patients that we can no longer, at least temporarily, accept telehealth calls under the waiver rules? We need to evaluate whether we should continue to offer these telehealth services, perhaps as an option that says you have to pay for it. We can't bill the Medicare for it. If you want it, we might bill you directly. That could be an option. How do we prepare to put telehealth and other services affected by the waivers back in place once the laws change, assuming they change? And what is the impact of losing telehealth on our overall staffing mix and profitability? So a lot of questions relating to the business of health informatics and health information technology. Now I want to talk about a new acronym, EMTALA. This is something that we don't see in the news very much, but is critically important. It's the Emergency Medical Treatment and Labor Act of 1986. It requires that all Medicare participating hospitals with emergency departments, it requires that they offer medical screening for every patient, stabilization for every patient if emergency conditions, no refusal based on insurance, immigration status, or ability to pay. Now, it's significant that this was for all Medicare participating hospitals, because Medicare generally doesn't provide funding for what this covers. Everybody of every age, whether or not they are a Medicare participant. So the result of this is that hospitals are required to provide unfunded emergency care to indigent, uninsured, undocumented people without question. They are required to do this. Which brings me to the Medicaid Disproportionate Share Hospital Program. So the requirement comes under, for any organization that receives and accepts Medicare, the funding to cover that comes from Medicaid, which is a more age-wise universal distribution, called the Disproportionate Share Hospital Program. That means hospitals that have a high rate of uninsured, of whatever flavor, whatever variety. And so it provides federal and state funds to help hospitals serve those people. It covers the cost of two things, really. The EMTALA required uncompensated care that we just learned about. It also is intended to cover Medicaid shortfalls. If you have a high percentage of your people covered by Medicaid and the Medicaid schedule in your state does not cover your cost, some of this disproportionate share hospital program wasn't intended to cover that shortfall. How many hospitals are participating in this program? 41% of all U.S. hospitals participate in this Medicaid disproportionate share hospital program. There are about 6,000 hospitals in the U.S., so that means 2,500 or so hospitals rely on this DSH program to cover the gap for uncompensated care that they're required to cover and for shortfalls in Medicaid. So, the current policy issue, the pending $8 billion annual federal cut for 26 through 28, that is the appropriation bill, threatens safety net hospitals, may reduce capacity, services, or force closures. That's brutal. What's the impact of the proposed cut in federal Medicaid then? So let's spend a moment and look at the numbers related to this. A little while ago, I told you that the One Big Beautiful Bill provides that the funding for Medicaid from the federal government would be reduced by, I think it's $863 billion, over $800 billion over 10 years. We need to distinguish that from this, which says that per year, the total of state and federal money on Medicaid is about $800 billion. And they say about $800 billion because it's come down a little bit in 2023. It was about $903 billion for 2023, combining federal and state Medicaid, of which $619 billion was from the federal government. That's roughly $90 billion per year out of the $619 billion that came from the federal government if we were to apply that in 2023. Against that, or of that, total Medicaid disproportionate share hospital payments were about $17 billion in 2023, which represented about 2% of total Medicaid spending. The significance of that is that while DSH is a small part of the total spending, it's a critical part of the revenue stream for safety net hospitals, hospitals in rural locations, hospitals in areas where the uninsured rate is particularly high. Indeed, even in areas where the high percentages on Medicaid, those will all suffer greatly from this. So then I said, let me show the difference between Medicaid funding and disproportionate share hospital funding. Direct Medicaid funding, payments for services rendered directly, funding mechanism is mandatory federal spending. The federal government matches state spending based on various formulas. It's unaffected by the shutdown because the money is collected separately. Payment claims processed continue as mandatory programs. Payments are guaranteed for the covered services. So Medicaid itself will continue. But the disproportionate share payments, supplemental payments to offset uncompensated care for Medicaid shortfall and costs for uninsured, that program was capped with a federal allotment per state. Again, One Big Beautiful Bill translates into a formula that says each state can have so much money for disproportionate share hospitals. That is highly vulnerable to current legislation in the Appropriations Act. And the reduction that has been presently proposed is one of the subjects that the Democrats are saying we want you to reduce that, to reverse that. Even if it was in One Big Beautiful Budget, we want you to restore that money to Medicaid to protect access to care. So what's the impact of the government shutdown and the appropriations proposals specifically on disproportionate share hospitals? Scheduled $8 billion cuts will take effect. The cuts mandated by the Affordable Care Act but repeatedly delayed are not automatically delayed by a shutdown. The inability to pass a continuing resolution or funding bill means the cuts will take effect. I want to spend a second on that. The Affordable Care Act, which provided access to close to 30 million people who previously had not had access, included provisions that said we ought to be able to get rid of the disproportionate share hospitals over time. The idea was that if you are providing access to insurance through the Affordable Care Act and the marketplace, you shouldn't need as much money for disproportionate share hospitals. We'll see what the overall effect is when we kind of wrap this up in a moment. The economic rationale is that $8 billion reduction in the 26 budget beginning October 1st is a pre-existing legal mandate. That would be the argument. We already had to do it under the Affordable Care Act. Congressional inaction results in the cuts being implemented by the Center for Medicare and Medicaid Services. Appropriations proposals, that's the effect of the shutdown. The appropriations proposals, temporary delay of DHS cuts. Recent proposals have aimed to delay the cuts until a later date, after November 20th. That would be under a continuing resolution. This is a short-term legislative fix to buy time for a long-term fix. Direct Medicaid benefits, no immediate impact, but Medicaid is a mandatory entitlement program, meaning its funding does not require annual appropriations, but you can still have cuts by making changes in how Medicaid works. For example, it may switch from a per-person, percent part of their insurance cost, effectively, to a block grant. We will give you so much money for your state. You figure out how to apply it to your version of a Medicaid program. So these are the ways in which the shutdown and the appropriations proposals will impact the disproportionate share hospitals. Key takeaways. Policy mechanics work, that's clear. How do we define this? What are the techniques, the specific tools of it? The number of hospitals affected will be 2,500 or so hospitals. A full 41% will have an impact based on the elimination of or the reduction in the disproportionate share hospital funding. How many people will be affected? Millions. How many undocumented illegal immigrants? This is important because we hear Mike Johnson, the Speaker of the House, and others say that the Democrats are only about providing funding for illegal immigrants, undocumented immigrants. The only place that I can see that undocumented immigrants receive health care funded by the federal government is through access to emergency departments funded by disproportionate share hospital Medicaid money. How much would be affected? Well, it turns out it's less than 1%. I think I have that in the next slide. Less than 1% of the population being served. But if you're in those hospitals, you might have a higher percentage of your uninsured people being undocumented. And so it affects both you as a provider and your patient mix. It also means that those people who are traditionally available to receive health care may not be able to receive it. It is a more significant percentage of the uninsured. So what are the implications short term? These are my observations. Medicare funding generally intact. Revert to the old rules for telehealth. Agency slowdowns because of furloughs. Interrupted or canceled funding. Increased reviews for DEI. I haven't really talked about that. We see that as a part of this review process, they are reconsidering money distributed in the past and saying, even if we come out of a grant with the certain provisions intact, we may have looked at them and said, your grant, your proposal, this program no longer complies with our focus on diversity, equity, and inclusion, or other initiatives that are inconsistent with what this administration believes, and therefore funding is at risk. In terms of the long-term effect, there will be a decrease in the insurance pool, with the healthier people dropping out of the program, which will increase the insurance costs at least by doubling that cost on average. The change in service mix reflects a change in the demographics to a less healthy population, which has a direct effect on what health informatics solutions we need, what tools we need. It means a change in priorities for research, including for health informatics. It means that health informatics and health information technology will become even more important, doing more with less. But we will also know that we will need to figure out how this aligns with the MAHA strategy that I talked about in Module 3, the strategy from the Department of Health and Human Services under Secretary Kennedy. And all this happens at a time of rapid, explosive technological innovation. So what are my takeaways? Instability. We can't look to the funding from the federal government with the same confidence we've had in the past. Furthermore, we don't know what the requirements, objectives will be. There is instability, there is insecurity about having a runway to develop new technologies or to know if these priorities will persist for more than the cycle we need. We talked in our discussion of the financial planning to think in terms of 3 years or 5 years. Right now, I don't know how well we can do that. It means that there's a lot more competition with scarce cash, particularly from the federal government. That means perhaps competition for non-governmental sources, whether it's through insurers or through other private equity funds or other sources of private capital. The competition will be fierce, which means that the business case becomes all the more critical. It means that understanding and expressing the business case is the critical component, not only to success for your health informatics and health information technology programs, but through this for healthcare in general, through these challenging, unstable times. So that's it for looking at telehealth and disproportionate share hospitals. Next up, let's go to lesson 3, when I want to talk about finding a solution for a health informatics program, particularly with respect to following our use case that we've been using around the ability to prevent suicide attempts. Thank you for watching.